as nurses, we aren't really given those skills. We're given those skills to be autonomous in our respected setting in the ER or ICU. But when it comes to like showing up on the side of a highway and knowing where to start and what information to get and also how to be quick about it all, we're not really prepared for that unless we seek those opportunities to prepare ourselves.
I gotta go. I've been working, told them please don't hit my phone. I'm in my zone, bruh, just leave me alone. Was on the road, but I swear I'm coming home. Now the drinks on me, I think we need a toast. See, I did it for me. Now my old friends calling, told them nothing's for free. Told me time is money, dog, swear I paid all my fees. I was starving for this game, now my family can eat.
Hey everyone, welcome to the Cup of Nurses show, here with your hosts, Peter and Matt, two nurses on a mission to change this world, one conversation at a time. If you find value in the show, please and review the show. It would mean absolutely everything to us. cupofnurses.com for the latest updates, merch releases, and show notes. Everything is on there. For our lifestyle podcast, you can check out wearefrontlinewarriors.com.
In this episode, we would like to introduce you to Madison Vawter. Madison is a flight nurse with a background in ICU, trauma, and ER. We talk about what a flight nurse does, how to become one, and how to build confidence as a nurse. Thank you, Madison, for being here. Thank you so much for your time. Can you give us a little bit of background about yourself?
Yeah, thank you for having me. First off, I'm pumped to be here and talking about nursing and flight nursing in general. I love it. But I am currently a flight nurse. My name is Madison Vawter. I have about 4 years of experience with nursing. I originally didn't go to school for nursing because I couldn't get into nursing school originally, believe it or not, but I always knew I wanted to be a flight nurse. But I got a degree in public health, a bachelor's of science in public health with a pre-nursing specialization. So I got all the prereqs done, and then I applied to a accelerated nursing program. So I got into that. It was 1 year of just intense BSN, 2 years worth of schooling into 1 year. And straight out of that, I started doing everything I could to get the qualifications under my belt for flight nursing, because those are pretty specific. And so for 4 years, I spent working in a level 1 trauma center on a trauma floor. And then that was for 1 year, and then an ER for 3 years. And as soon as I met the minimum qualifications for flight nursing, I applied. And so here I am. I'm a little over a year into that, and I love it. And I never want to change careers as of now. So.
And what pulled you into flight nursing? That's something that was always on your radar. I know you mentioned that you didn't want to go into initially, but what was the main attraction of it? Was it like the rush? Was it the thrill? Was it getting to work in a helicopter?
I think it was the mix of when I was in high school, I was really intrigued by like firefighting and paramedicine. I really wanted to be. I love the first responder aspect of things. That attracted me a lot. So I did a job shadow in an ER, shadowing more of the process with the EMS squad, like when they'd come into the ER and watch that process. But I actually got to see some flight crews bring in really critical patients. And so the mixture of pre-hospital care and the more like critical care aspect of nursing combined, seeing that in action when I think I was like 14 when I was shadowing all this, I was like, that's what I want to do. I get a mix of both pre-hospital knowledge, and then I also get to have this critical care aspect that I get out of nursing. So that's when the light bulb clicked on.
And as far as a flight nurse, how is your routine? I know if you work regularly in a hospital, you're doing 312s, either working days or nights. How does it work for flight nursing?
So everywhere you go, like regionally, it's different. Where I'm at, I'm actually afloat for my program. So I work 2 24s a week, whether or not it's like 24 on, 24 off, and 24 back on. That's how the normal schedule is. I'm a little spread out though, because I'm afloat, but it's 2 24s a week. Other programs though, like in my last job, I flew in Iowa, Nebraska area, and that's a little more of a rural location. And so the rural locations, it's hard to get people that live in those small towns. So you'll work more days on, then you'll have more days off. So it encourages people to commute to the rural bases. So I used to work, it was like 3 24s and a 12, and then I'd have a week off. Now it's more, I don't have as many days off with my current schedule, but it doesn't bug me too much because I work in town. So it's easier.
And then as a flight nurse, do you work in just a helicopter, or do you work in like an airplane? I know there's different types of flight nursing. So what have you done?
So my current program, we have a helicopter, we have a fixed wing airplane, and then on bad weather days, we do ground runs. So we have a critical care ground unit. My previous program, we were strictly helicopter. So that was always hard when you'd have bad weather days because you'd get a call and you'd have to just flat out turn it down. And out here, even if we have bad weather days, we are not turning down the patient care. We're turning down the flight, but we'll go by ground to get that patient, or we'll go by fixed wing in the airplane if that's feasible. So I like the mix of all three that I have right now for sure.
And what are responsibilities maybe during downtime? I know, for example, firefighters, I don't know what they do in a firehouse, but they maintenance the truck or the engine, whatever. So what are the responsibilities when you don't have like a high acuity patient load?
Yeah, so it's pretty similar to the fire lifestyle. My husband's actually a firefighter, and so it's funny, our mornings start pretty similar where we'll come into work and we have to check our individual rigs. So my rig is the aircraft. So I'll come into work and we'll check our aircraft. We'll make sure we have enough oxygen. We'll check all of our equipment. We'll go through all our bags, make sure that nothing's expired, make sure everything's functional, make sure batteries are charged on our intubation stuff, on our pumps, our ventilator. We'll do like a check on everything that we might have to use. We make sure that it's functioning properly. And if it's not, we'll troubleshoot it. We'll restock things. We will also we get involved with the aviation side of things with our pilots. And so we're learning about weather. We're talking about weather all day. We're talking about different aspects of just what to expect if we get a call. And we're learning about, and if you don't know a ton about like the weather aspect of things, you're learning about it from your pilots, because it's important when they tell you we'll talk about tonight there's a 2-degree dew point spread, and that's a specific number that indicates whether or not it might get foggy. And so we're learning about what that means, because that affects whether we want to accept a flight or not if we feel safe. And so we're learning a lot about safety, in addition to checking our materials that we're using throughout the day. So there's a lot of things that you can always learn, work on, study while you're at work. And then we have a training room. So if we're not on a call, we have our training room at our disposal where we can practice intubations. And this dummy has the ability you can have a contaminated airway, and it throws up coffee grounds, so you can practice salad techniques. So and we have a gym, so we have a lot of things at our disposal.
That's super cool. And then when you're on the aircraft, what does your team consist of? Is there like a PA or a physician, and there's pilots? Do you have access to like respiratory therapists? What's like the team look like? It sounds like it's a combination of ICU and ER and trauma, and you're doing all of it. Are you doing it all by yourself, or how does that look like?
So every program once again is different. My current program is we have nurses, we have paramedics, and then we have respiratory therapists. And at my previous program, and majority of programs are just nurse paramedic. But mine, you always have to have a nurse on the aircraft. In some situations, you can have a medic RT or medic, but they can only take scene calls at my program. But as far as staffing goes, and that happens if a nurse calls in sick and there's only 2 medics, or a nurse or a medic and an RT on, they can only accept scene calls for the day, but they'll staff the aircraft with a nurse and a medic, or a nurse and an RT. And our roles, our scope of practice when it comes to being in the air, they're the same. We're no different than each other. It's not like one person is in charge over the other. Our scope of practice, the things that we can do while we're taking care of a patient, are the exact same. Obviously, I look to my RTs to work with the ventilator. We're all trained on the ventilator, but the RTs, we learn a lot from them because that's their thing. But they can do everything a nurse can do, and we can do everything they can do.
So then, for example, if it's just you and an RT, is the RT the one intubating, or how does the role switch a little bit?
Either or. We always, depending on who you work with, most cruise, you have your set partner. I'm unique where I'm afloat, so I always have a different partner. And so when you have a set partner, you guys kind of, your flow. Like if one person's like, dude, I'm so tired of intubating, like you get this hitch. But with my lifestyle being afloat, I always talk with whoever my partner is and I tell them like, hey, I haven't had an intubation in a while. If we get one today, can I do it? Or if it's like, if it seems like a difficult airway, I'll let you and I talk about it. And I prefer you to take over if it's a difficult one, because the RTs have more experience with that. And so do medics. We'll talk about kind of our roles and our pregame, especially when we get a call. We get that like quick brief report before we take the call. We'll kind of go over, okay, I'll start this, you start that. If this happens, I'm okay with doing this, or I prefer you doing this. So a lot of communication to discuss just what our game plan is.
And as far as like orders, since there's no physician on board, are you communicating with somebody in real times for orders? Is there like a set protocol that you follow, just like paramedics, and the patient arrives to the hospital and everything gets taken over?
Yeah, so similar to paramedics, we have a protocol book. We do have a physician on call at all times. You can call our medical director whenever we have a question about something. The protocols, it's really a big gray area for nurses. As nurses, we're used to always having the doctor right there at our disposal, and we know our protocols and we know what's in our scope. Like working in the ER, I knew what I was able to do and I knew what I wasn't able to do. And here you have these set protocols that tell you what you should be doing for your patient, but it's still not, it's never does a patient actually perfectly fit into those categories when it comes to like a decision making process. So there's this big gray area where you have to use your critical thinking skills and you have to use your judgment as a critical care provider. And as long as you can justify that, you have the freedom to act on that. So like, for example, let's say I had a patient one time that they had a head injury and I was concerned that they were seizing. Well, I had already given them benzos. I technically, per my protocol, you have to meet a certain criteria to give Keppra, but I could justify starting a Keppra infusion, whether it was prophylactic or was treating a seizure that I was actually witnessing. So we can justify our actions. And if you ever have a question, if you don't feel comfortable justifying an action that's not perfectly per word for word, you can call your medical director in the air and on the ground. You can call them anytime.
Can you give us like a description of how your workflow goes? So for example, you show up to work, you get assigned, then let's just say an emergency comes up. Do you get like a quick debriefing on the plane, or do you get it as you're boarding the plane? And then you guys load the equipment? What is like let's say you get called in for something happening. How does your workflow look?
So we'll get a call and we'll hop out of bed or stop what we're doing and we'll get together with the pilot, our partner, and we'll kind of first assess weather, and we'll make sure like, is weather good at our destination? Is it going to be okay coming back? Is there anything that we could run into that poses any risk? And we'll discuss if we're all comfortable taking the flight. And if we are, we'll communicate that back to our dispatch and we'll accept it. And at that point, they give us our patient info because they don't want to give you any information that might sway you into thinking like, well, it's, the weather might not be good, but it's a baby. Like we want to help this baby. Like they don't want to give you any information that might make you make a decision that isn't the safest decision. So once we accept the flight, we'll get our patient info and then we start moving. Our pilot will go out, get the aircraft ready. Me and my partner will get our drugs. We'll get, if it's a scene call, we'll get our scene, we call them bras. They have just like a ton of stuff to start IVs, have tourniquets, decompression needles. So we'll grab whatever supplies we need for that call and we'll start kind of talking through our game plan. I like to call it like the pregame of when we get on scene. I'll go in the side door, you go in the back door. If it's an IFT, we'll discuss more en route, but kind of go with our game plan. We get in the air, we get our patient weight, and my personal thing that I like doing is I calculate all my drug doses for RSI. So I'll calculate every drug that I might need to give during the care of this patient. so that I have it there on me so I don't have to try and do math in the air, because we're already going to do math in the air when we're mixing drugs. So we mix all of our own drugs. So I get all my doses out. And that's pretty much the main thing that I want to get done before we're at the patient, those emergency RSI meds. And then after that, we show up on scene and we'll take all of our bags out that we need, and start doing patient care and see what we have.
Are most of your calls like scene calls where you're maybe me picturing these events would be you landing on a highway or something, there's a car crash and you're troubleshooting, or is it mostly scenes like that, or are you picking up patients at hospitals and doing transport runs?
It's a good mix of both. Where I'm at currently, we're surrounded by a lot of rural areas that are surrounded by mountainous regions. So if they have something critical, it's going to take a long time to get them to the resources that they need. So we're flying, if it's a scene call, depending on the town. Some towns we fly to a lot. They have a large population of people that they have a lot of cardiovascular problems. So we respond to this community a lot for STEMI calls. And so if we have a good relationship with this community, we've been there a lot, they'll develop an LZ that we have like pre-decided with them. Like if we go to your town, we're going to land on like one town, it's a stretch of highway that we land on. They've closed the highway and they set up an LZ there because that's the safest spot for us to land. Or other towns, they'll have like a set parking lot. Like if they have a big church that it only has people on the weekends, that's our set LZ on weekdays. So it just varies from town to town. If it's a car accident, yeah, we're landing as close on scene as we can. If it's somewhere where it's on like a very mountainous highway where there's no way that we can land, they'll meet us wherever the closest spot is. Like they'll tell us where they want to set up an LZ. We'll take a look at it from above, and if it looks good, we'll go there. If it doesn't look good, then we'll tell them like, hey, we're not comfortable with this. Like we see power lines, or there's a slope. We don't feel comfortable with this. And since we're in the air, we can kind of tell them like, hey, I think there's somewhere like down the highway we can meet you that might be a little safer. So everywhere's different. And with hospital calls, we do a lot of interfacility transfers as well, where we're picking up a patient from a smaller hospital that doesn't have the surgical services that a patient needs. And we're flying them, whether it's to the trauma center that's across the state or just to the closest center that has a STEMI capable facility. We'll fly them there. So it's always different. We never know what you're going to get.
Do you have like a favorite type of case or something that you prefer to respond to, like maybe like a trauma one, or do you prefer like the STEMI cases? Does something give you more of a rush than others?
I love my traumas. I spent 3 years in a level 1 trauma center that was like a knife and gun club, where it was in the very populated metropolitan area where we just got a lot of really serious traumas. And so that's my bread and butter. I love taking care of those patients. It's one of those areas that I wouldn't say that it's like a rush. It's just, I know that it's a very stressful patient for most people, but I love it because I've had so much of it in my experience at that hospital that I was in, that it's like, this is where I'm ready. I know that I can think clearly. I know that there's trauma triad of death. It's always on my mind, and I know exactly what I need to do to mitigate that from happening. So, and neuro trauma, I enjoy. It's like sad to say, I enjoy neurotrauma, but there's just certain aspects of like neuro and trauma that I enjoy the processes that go into caring for a patient like that.
Mm-hmm.
What's the term do you guys use for the helicopter? Is it just a helicopter? Do you guys call it a bird? Is there like a slang term for it?
Rotor, we call it, or rotor heli. I mean, some people call it the bird. I don't call it the bird because I don't know. I just call it rotor wing and then fixed wing because since we have both aircraft.
So like in the rotor wing, I'm curious on what is the workspace. So regular hospital, anybody that's listening, you have your patient's room, and then you have the Pyxis and a nursing unit. How is the workspace for the rotor? Are you at the front of the head? Are you able to move around? What does that look like?
So traditionally, you have your patient. So I'm in two different rotor wing aircraft. So I fly in one that it's an EC-135 and it's big. It's got a lot of space, and the patient is kind of equally there's still someone at the airway, but we have enough room where we can move around and help this patient. And then the other aircraft that I'm in is an A-Star, and we're packed into this aircraft like sardines, and the person at the airway is pretty much sitting on this patient's head. And if I want to get over to the patient, I can't. I really can't. So depending on the aircraft, normally, like traditionally, the paramedic will be the one at the airway, or the RT will be the one at the airway, and then the nurse is on the other side where they have disposal of like the drugs. You have your monitor, your vent, more accessible, but in reality, we're all able to reach those things. It's just easier for the nurse, if they're not at the airway seat, to draw up the drugs, show the partner, okay, we'll give it. And so it's just, it depends on which aircraft you're in. It took me a while to get used to the process of where to set things, because once you're in there with the patient, there's really, if you need something that you haven't gotten out beforehand, you're gonna struggle to get something out. Like, we had a patient one time where I was like, we're getting the aircraft, I was like, okay, wait, let's grab the hypertonic saline just in case, because I know for a fact once we're all packed in here, there's no way that we're going to be able to reach it, because you're packed in so much. And the bags are normally stored on the patient cot. Well, when a patient's there, those bags are going at your feet, they're getting strapped down, they're right up next to you getting strapped down, you're bunched in there. The plane is different. The plane, we have a lot of room, and the bigger aircraft, you're not as squished in, but it's still, you got to prepare. You got to think beforehand, like, what will I most likely need access to? I want to make sure that is in arm's reach, because if it's not in arm's reach by the time we're in the air, it might as well not even be here. So a lot of thinking ahead, thinking what might I need, goes into play when you're taking a flight.
And Madison, I gotta ask this question: what's like the most intense case you've been in, or one that you really, really remember well?
Gosh, I I used to fly in the Midwest, and so there were a lot of, summers in the Midwest are really hot, really humid, and people in the Midwest, they live in very rural, a lot of farm folk. And I worked in an area where we were surrounded by a ton of farms, and a lot of just your typical farmers, tough guys who just, they're okay, even if their leg is, even if they have an open fracture, they'll walk it off. They're all really tough out there. But so flying out there, I saw really cool stuff. One specifically, we had someone who pretty much, they had they had been witnessed mowing their lawn and collapsed while mowing their lawn. The ambulance was driving by at the time and watched this person collapse. They were coating them on the lawn, in like 104-degree weather. They ended up they're having a STEMI, but the fact that this patient, and it was in a really rural area, and the fact that an ambulance happened to be going by was amazing, because the odds of that in this town are like slim to none. They saw it. They called us right away. We got on scene. They got Rosk. We kept him alive long enough because he was trying to go back into VTAC, and we had a 30-minute flight. It was so hot that day, and in the aircraft, it's like a sauna in there. And especially when you're trying to do a ton of things for a patient in a short amount of time, you're drenched in sweat. And so my partner and I we're working hard to make sure that we don't let this guy go back into a fatal rhythm. And because if you start coding in the aircraft, you have to land. You can't keep flying because we don't have enough room to really safely code a patient. So you have to go to the closest hospital. So we would have turned around and gone back to the small town that we are in that doesn't have a cath lab. So we're trying our best to keep this patient alive, and just this partner of mine, she and we worked so well together. And so I think that aspect of it made it such a memorable flight, because we got this patient tubed, we got him on the ventilator, we got them to the hospital, and we landed on the helipad. And at that point, and this is the hospital that I worked at, and so I knew everyone in the ER, and so we notified them ahead of time, hey, we need help in the pad because this patient, we're struggling to keep them alive right now. And so some of my favorite doctors and nurses from the ER that I worked in came up and met us up there, and we all worked together to get this patient down to the ER. And they went pretty much straight to the cath lab. And a week later, not even a week later, it was like 2 days later, we got a call from the nurse that was taking care of him in the hospital. And he woke up and he was like, last thing I remember, I was mowing my lawn and now I'm here. So he was perfectly fine. And so that just, those are the calls that like mean the most to me, where because a lot of them, like, they're crazy calls, but they don't have great outcomes. And so those calls that could have gone so much worse, where this guy could have been on the lawn and died, then no one would have found him for hours. The fact that everything worked out so perfectly, and he lived, and he woke up and his first words were, why aren't I mowing my lawn? I love that. I love that for him. And so my partner and I we were so pumped to hear that, because it was one of those calls where we were so miserable. We were so sweaty, but it didn't affect us at all. Like, the way that we worked together was awesome. And so that was huge.
Yeah. That's working in the ICU. You always get like a good feeling when somebody makes it, because the expectation of you making it through, like especially a cold situation, is very minimal. So it's like you remember those really well, because a lot of times people pass and they don't make it, or they get a brain injury where they lose oxygen and then they're never the same ever again, and they never wake up. So it's like those are always really good to see, because you actually feel like what you're doing is actually paying off. Sometimes working with like older patients in the ICU, you're just like means to an end in a sense. But when you actually see people recover, it's just like, okay, damn, like this is how it's supposed to be. It's how it's supposed to feel. So I want to follow up. What's the craziest trauma you've seen?
As far as in the helicopter, I personally haven't had a really crazy one. The people I worked with have had, well, I guess, I don't know, it's hard. Like, I've had like crazy ones, but the craziest ones I've seen were when I was working in the ER still, because I saw so many then. And so nothing that I've done flying compares to what I saw in the 4 years that I did in the ER. But so I guess I'd rather tell the one that was in the ER, because this one was impressive. Pretty much someone was ejected high rate of speed, and we would have gotten called to fly them. My helicopter would have, but they were in town. But anyways, they were ejected without their legs. Their legs stayed in the car, and the rest of their body got ejected. But they lived. It was bilateral below the knee amputations, traumatic amputations, and the fact that they first off, they weren't even tubed when they came in. They had bilateral tourniquets, and they were in a lot of pain, so we tubed them right away. But they lived, and went up to the OR fairly quickly. But like 30 minutes later, we're cleaning up the trauma bay, and the fire department shows up. They're like, I have these legs. Do you want them? But they had socks and shoes on. I mean, it was just, it's insane what trauma can do, like that type of force. And drunk driving. So word to everyone, don't drink and drive, because and don't get in the car with someone who's drinking. That person wasn't even the driver, and they weren't even intoxicated. The driver was. And now their life is forever changed. And I can't imagine the force that it took to amputate 2 legs with such it was crazy. And I saw pictures afterwards when they took the legs out, and they were sitting right there in the passenger seat.
Yeah, I'm trying to figure out how that would happen. Like was it a seatbelt that held the legs in place, and like the rest of the body went forward? Like I can't even think of that, like how an impact would do that without like cutting it with a saw.
Right. Because if they got ejected, like, wouldn't they have they probably weren't restrained. I don't know. There's always, and whenever I would get patients like that, I'm like, I want to learn more about why this happened. How did this happen? But you get so busy, you just becomes a thing of the past, because you have another trauma right after that. But yeah, I never learned the details, the mechanism of all that, but I know they're at a very high rate of speed. They hit a pole.
I'm,
Yeah.
I'm glad he survived. So switching gears here a little bit before we talk about other things, and anybody that's interested in flight nursing, what are the requirements or the educational ways or the experience that you need to get into flight nursing?
Yeah, so pretty much the majority of flight jobs require a minimum of 3 years in an ER or ICU setting, or the combination of the two. And they look for specifically you have experience in a higher acuity ICU, like in a bigger hospital, or a higher acuity ER in a bigger hospital. 3 years are normally the minimum. And that's what I had the minimum 3 years in a high acuity ER. But on top of that, like that's the minimum for everyone. So you have to do something to set yourself apart. So in those 3 years, I got as many certifications as I could under my belt, because that makes a huge difference, and they're required as well when you get into most flight jobs that either require your CCRN or CEN, and your CFRN once you're working in the flight setting. So I got my CEN and my CFRN. I did all the basic, the PALS, ACLS, TNCC, PHTLS, pretty much any certification I got done. And that's what you got to do to set yourself apart, and join committees, join different committees at your hospital, and join like the ENA, the Emergency Nurses Association. There's all those different associations and society, like nursing societies that you can join and be a part of their newsletters, get their newsletters, and join those. Being a part of those things and showing that you have chosen to take steps to learn more about your respected field, that shows a lot of your desire and your drive to be a good nurse and be a good flight nurse. And so you gotta take those extra steps to set yourself apart when it comes to applying for these jobs, because the minimum requirements are the minimum. So I knew that when I started off, and so I pretty much I made a list of every month I wanted to get different certification, and so I did that for like 2 years, the first 2 years, or over the course of the years that I was not a flight nurse. I pretty much always had something that I was working on, whether it was taking a class, getting a certification, going to a seminar about trauma or pediatrics. I wanted to show that I am still learning something. I'm never not learning. I always want to be adding to my knowledge. So.
And as far as like the market is very competitive to become a flight nurse. I know, for example, firefighters that get the job in their unit or in their engine, they stay there for a while because that's what usually firefighters do. As far as like flight nursing, once you get your position, is it very long term for flight nurse to stay there, and it becomes very hard to get another position?
Yeah. Well, as far as it's very competitive, yes, to get into it. And I actually, when I first applied for my first flight nursing job, I didn't even tell my husband that I applied, because I was like, well, I only have the minimum requirements. I'm probably not going to get the job or even an interview, but I want to ask them what I can do. I want to get on their radar. Well, I got an interview. I told my husband, well, I got an interview for a flight job. He's like, what? I didn't know you applied. I'm like, yeah, well, I'm probably not going to get it because I have the minimum requirements. Because they also, during the interview process, you have to take a test and you do a skills test out before you even get to the interview process. And so I was like, I'm just going to see what this is like, get a feel for it. And then I got offered the job. When I was in the gym, they called me and I broke down crying in the gym, because I didn't expect at all to get this job or even an interview. And so that's how out of reach it felt for me. And so I was elated to get that job. And then my husband, because I was living in an area that I never planned on staying for the rest of my life. My husband and I were trying to move back towards my hometown. And of course, like a couple months into me flying, he got a job back towards my home. And so I was like, oh, I'm leaving my flight nursing job that I worked so hard for. But I didn't, because I actually got to transfer to another base in the state that I'm living now, because they were within the same like sister company. So that was amazing because I was like, great, it's going to take so long to get my name out there again because it's very competitive and jobs don't open up a ton. So I was really lucky to get to transfer. But yeah, most people they don't leave very frequently. So yeah, jobs don't open up a lot. And when they do, we get a lot of applicants. And like I said, they have to go through a paper test and then a skills test out and then the interview. So it's a pretty extensive process. And I mean, a company will go months, if not like a year, without hiring someone if they're not going to just hire someone because they're desperate. They need to make sure that they meet the requirements for the job. So my current place of work, we've gone the past 6 months needing a nurse and finally hired one. So it is competitive, but also I don't think a lot of people realize because the job description doesn't tell you like you need to display that you have a good understanding of pre-hospital care. Your test out is going to be based on pretty much pre-hospital care. So knowing that you need to come into it with a good solid background when it comes to your, like, you need to know ACLS like the back of your hand. You need to know the trauma nursing process like TNCC, PHTLS. You need to know that those processes like the back of your hand, and you need to be comfortable to act on those scenarios when they test you out like it's nothing. And so for anyone who wants to go into that field, get comfortable with those processes, practice scenarios at home, and talk to your local paramedic. My husband was a great resource because he put me through scenarios that he had on calls. If it weren't for him and it weren't for me knowing paramedics, I really would have never got a great grasp on what these processes look like, because in the ER we have our ER processes and they're totally different than being the sole critical care provider on scene that you are in like the paramedic setting. And then in the flight setting, you're two critical care providers coming in and taking over, and you need to be comfortable with being the one in charge. And those are the skills that as nurses we aren't really given those skills. We're given those skills to be autonomous in our respected setting in the ER or ICU, but when it comes to like showing up on the side of a highway and knowing where to start and what information to get and also how to be quick about it all, we're not really prepared for that unless we seek those opportunities to prepare ourselves for it. So
And then as far as like the flight programs, are they independent of the hospital? So does a hospital system own these programs, or is it more company based and the hospital brings a company on to manage the flight program?
it's a mix. My program right now, we are affiliated with a hospital, but that's because our hospital needs a transport provider for neonatal patients because of how rural they are. And so they are affiliated with us so that we can provide neonatal care and transport neonates to a hospital on the other side of the state. Children's hospital, Children's hospital normally has their affiliated transport crew. So it's just kind of it's hospital dependent. But my company is still related to a sister company that has independent bases that aren't affiliated with hospitals. So it's just kind of dependent on the hospital's needs, I guess.
And how does the onboarding and education process look? Is it, for example, you're flying with another nurse for 3 months before you're flying solo? Once you get hired, how much time do you have, and how much education do they provide before you're actually just doing it on your own?
So my first job that I had, first off, you go to, before you even get on the helicopter and take patients, you go to wherever the headquarters is for your company, and they put you through like a 1 week long orientation where you're in class all day, learning about aviation and safety. That's a big chunk of it. You get trained on night vision goggles. And then after you get all the aviation side of things done and the safety side of things done, you move into learning about, they pretty much review all of the critical care skills that our protocols cover. So it's a lot in a short amount of time. And so you do all that, and then you'll get in a helicopter, do your NVG training, you'll fly around, and after that, normally you'll go home to your base. And then as a nurse, you get paired with a paramedic at my previous job, since we didn't have RTs. My current job, when I got onboarded, I was with either a medic or an RT. And it's dependent on the person's background, how long you're on orientation, whether it's like for 6 flights or 6 weeks. It just kind of varies on your experience. So my first job, it was, I think I had to get so many patient flights over the course of so many weeks. And if I didn't meet that, then I would still fly with a preceptor, but my preceptor was my partner. And so my orientation process was strange. We just kind of like, I was on orientation until I wasn't with him, because it wasn't like I was going on my own, because since he was my partner. But here at my current job, I had to get so many flights with my preceptor before I could pick up shifts with people who weren't preceptors. So I got 15 flights over the course of 2 weeks. And and normally it was like, you'd be in orientation for 3 weeks. Well, since I hit so many flights in a short amount of time, they're just like, okay, you can go. Because I had met the requirements, and my preceptor was like, she's fine, she's good to go. So person to person varies.
And then you mentioned you had some aviation education. Then, for example, worst case scenario, something happens to the pilot. Do you know how to fly like a helicopter or airplane, or know at least what buttons to press in case something happens?
I know what buttons to press to keep us on autopilot and keep us stabilized. They do give you in the previous aircraft that I was in, they did give us a course on how, it was a video, like a 10-minute video on how to land the helicopter. And it was specific to that helicopter, because in that company that I was in, we actually had an incident where the pilot was incapacitated with the crew and the patient on board. He was having a stroke while flying. The crew had realized that he was having aphasia, and they looked at him and noted that he had facial droop. And so they're calling a mayday, and they're trying to talk them through pretty much how to possibly land it, but they never got to that point, because it's a pretty interesting video. You can look it up. It was an air evac case, but the story is crazy. Essentially, they're almost out of fuel, and then the pilot was like, out of nowhere, land there, and they said, okay, yep. And he actually landed the helicopter in a field while stroking out. But after that situation, they did kind of prepare us for, okay, this might happen. So if this does happen, here's a crash course on how to land the helicopter. I don't know if I could actually do that, but I know how to stabilize it, put in autopilot, and pray.
Yeah, that's intense, because it's like, one of my fears always when I'm flying is like, what if something happens to the pilot? Like, am I going to be able to figure out how to do this? Am I going to have like put on a headset and communicate? Like, am I landing this bad boy, or what's going to happen? Because, it's very rare, but if it happens, it's like, it's a crazy feeling, because you're just out of like, you just really have no idea what to do. You can't, it's like hard to figure out on the spot.
There's so many buttons in there, and it's like, even if they were to tell me, like, press this button, turn this on, it'd take me 10 minutes just to find the button that they're talking about, because these helicopters are just insane. I feel like I could land a plane, because have you heard about that guy in Seattle? He like stole a plane a couple years back, Rich Bebo, and he stole a plane, and he was flying it around for a few hours. And he's like, oh, I played a video game once. This isn't too hard. So, since that guy was able to fly a plane, maybe I'd be able to fly a plane, but you don't really hear about people stealing helicopters, because they're pretty intricate machines.
Yeah, that's for sure. And then if you're a flight nurse, do you get to pick up patient population, or it's like you're a flight nurse, you're going to automatically have to know how to work with children, middle-aged adults, older adults, or do you have like a say in all that, or just as emergency comes, it just comes, you got to be prepared for everything?
Pretty much that. I mean, we have to be prepared for everything. In my current company, my previous, there's other companies where they don't have the capabilities to fly neonates. They don't have an isolette. We have an isolette in one of our 2 helicopters, and we have the ability to put an isolette in our airplanes. Um, we also have the ability to fly balloon pump patients. Other programs don't have that ability to fly balloon pump patients, or they don't have the ability to fit an isolette in their helicopter. So, but mine that I'm currently in, we take it all. There's nothing that we don't take. If they need our help, we're there. And if we've never worked with something before, we're going to figure it out with the doctors at the bedside. So that's something I love about this company, is that there's really, it could be anything. You never know what your call's going to get. It could be something that you've seen a million times or you've never seen or never heard of. So and you're going to take it. So it's
Yeah.
pretty cool.
Just listen to this interview with you and everything. It seems like it takes a lot of autonomy and confidence to be in a position that you are. And a lot of new grad nurses that listen to the podcast or message us, they always struggle with confidence early on in their nursing career. So being in a current, specialty that you have with all your experience, what are some tips you could give to new grad nurses or nurses in general that are struggling with confidence and building confidence?
I will be the first to say that I struggled with confidence so much because I couldn't even get into nursing school in the first place, but I never lost the hunger for my dream job, which is flying. And so don't ever lose that motivation. I mean, sometimes it's hard to find motivation when you hit dead ends and you feel like nothing's going your way. Like I've been there, and I let all of those failures that I ran into just serve as fuel to motivate me more to learn more on my own time and study more on my own time. Go above and beyond the requirements when it comes to school, when it comes to jobs. Do everything that you can to stand out, not for others, do it for yourself, because over time those failures, they're going to motivate you to being a better clinician, being a better nurse. And over time you realize, wow, I'm confident in myself because I've done a lot of extra work to get to this point. And I don't know, there's never really a point where I still struggle with confidence. We always will struggle with confidence. I guess that's what keeps us motivated to continuing to push ourselves and learn. If you are at a point where you're 100% confident and you feel like you know it all, then that's not where you want to be. Like, you want to be in a position where you know that you're not the smartest in the room, where you know that there's things you have to learn, because you should always be seeking out opportunities every day to learn more. And so that's kind of where I've been at. I know that especially at my current job, I'm the youngest one in my program, and that is hard. And it's fueled me and it's encouraged me to just be true to myself, be confident in myself. And when I don't feel confident in something, I'm gonna seek help. Like, there's people in my hospital that I worked in, there's people in my company that I fly for now that I look up to, I admire. And so I will reach out to them and I'll ask them, hey, can we sit down and talk about this? I want to know, like, your thoughts on this process. I want to learn more about your experience in this. So just never stop learning, and at some point you'll enjoy the autonomy. That's where I'm at. I enjoy the autonomy. I know that I'm not the smartest in the room, and I'm totally okay with that. I love that because I have plenty of people around me every day that I get to learn more from. And so it's just a constant learning process, and just acknowledge that. Don't aim to be the best at something. Aim to be the lifelong learner and enjoy autonomy. I enjoy being independent because I've worked so hard to learn new things every day, every year, and those things add up. And at some point you're like, I know how to deal with this, and I feel good about taking care of this patient because I've done this before and it's had a good outcome. So I don't care if I'm the youngest one in this company. I've done this before and I've done it right, and I might learn something new today. I might do something that that I should have done differently. Like, you're always learning. Just acknowledge that you are always going to be learning something new every day on the job, and it becomes fun. So I don't know. That's a huge topic for me because I struggled. I don't know how many times I was like, I don't know why I'm trying to do this. Like, I'm not I'm not smart enough to do this. I don't have like I didn't have the 4.0 GPA. I struggled at school. I was in school and I had zero confidence in just my ability to do a math test. Like I am the queen of no confidence when it came to my education, but I didn't give up. That's the thing. Just don't give up.
Yeah. Yeah, it's really good advice, just to be a lifelong learner. And like you said, you don't have to be the smartest person in the room. That's not your job. And you shouldn't think that you're the smartest person in your room, because then you're putting a whole lot of pressure on yourself if you don't know something. And if you think you're not the
Exactly.
smartest, that takes a lot of pressure off. And it doesn't make you seem incompetent. It's not something that you don't know something. It doesn't make you any less of a person or any less intelligent. It's just you don't have to be the smartest person in the room. You just have to understand that what you know through experience, through knowledge, through books, through whatever you've been through, and other people
Hmm.
might not necessarily that they might know more than you. It's just they know different aspects, different things because of their own experience.
Yeah. Like my favorite thing quote is get comfortable with being uncomfortable because that leads to opportunities to learn new things and speak up when you feel uncomfortable because otherwise you're missing out on an opportunity to learn from someone else around you or learn something new from others. And the nice thing about flying is after every chart that we submit, someone does a peer review on it and they give you feedback. First off, they make sure that you followed the protocols properly, you did all your dosages properly, but they also give you feedback and kind of like what they would have done differently, maybe what they're like. Oh, I'm proud that you did this. I wouldn't have thought about that. Awesome job. We get a peer review process, and that's always really awesome because every call. I mean, if you and your partner do your patient care, you send the patient off. It would suck if no one gave you feedback on your performance because how do you know if you could have done something differently? So that's a nice aspect of flying is the career, I mean, itself, they acknowledge like we are always learning and we all come from different backgrounds and we can all learn from each other. And so it's a really supportive environment, honestly, and that it's helped a lot. At first, it seems really intimidating, like thinking about like flight nursing and being a flight medic. It seems like such an intimidating field, but it's full of support and encouragement, and everyone is just such a big family. I mean, we're not a team, we're a family. And so if you ever see, your local flight nurse bringing in a patient to the ER, talk to us. Like I love talking to, especially students. Like, God, I loved when I was in the ER and I got a precept because I was one of those students when I started off in my career or when I started off in nursing school. I felt like my preceptors didn't want me there. I felt like all they wanted me to do was do vitals for them. And if I asked questions, I was a nuisance. And so I made a point of I am never going to be that nurse who makes someone who's learning feel like they're a nuisance for wanting to learn. And so I love advocating for students. I love advocating for new nurses, and I love I love giving just my stories and experiences because I've been there, and it sucks sometimes, but it's not the end of the road when someone tells you no, or when someone tells you I don't have time for you, go do vitals. That's not the end of the road. So
Yeah, right. Yeah, we have a very similar mindset to yours. We always say get comfortable with the uncomfortable, because that's just how life is. If you're comfortable, someone's going on. There's something that you're not seeing. But I'm curious, since you've worked both trauma, intensive care, and then the ER, did you struggle transitioning to being a flight nurse? Was there anything that you had to really hone in on to improve on, or anything that you struggled with?
I I I think that the scene call aspect, I still struggle with that. I mean, being nurses and being used to the hospital, being used to a controlled setting, it's not something that I'm ever gonna really feel like as comfortable with when it comes to showing up on a scene call because I feel so much more comfortable with showing up to an ICU or an ER and taking a really critical patient because that's just I have all the resources there and I can if I need meds if I feel like my patient that I'm picking up can you bowl some propofol before I switch into my meds, I can do that. Like I can utilize the team that's there on scene. I don't have any of that, and so it's still one of those things that I struggle with when it comes to just being okay with not having a ton at your disposal and moving fast. Medics are good at showing up on scene, loading and going. As nurses, we see a critical trauma patient or a critical, like, stroke, any scene call patient, a stroke, a STEMI, a trauma. We see this patient, we know, like, oh, I can do this, this, and this, and this right now. Like, I want to get this med started. You don't have time for that. Like, you need to learn to prioritize the things, because the thing that these patients need are a higher level of care in as quick of a amount of time as possible. So finding that happy medium of providing critical care that is the priority and moving with purpose, getting that dance, that it's just like, it's a dance, I like to call it. You got to just find that perfect mixture. And I still working on that, because I still show up to a scene and I'm like, oh, I want to do this and this and this, and then my medic partner's like, no, we don't need to do that right now. We can do that in the air if we have time, but we need to do these things and go. I'm like, okay, fine, but I want to do these things. So we think so critically as nurses, when we need to think more. Time is of the essence, and I'm finally getting the hang of putting the critical care things in my back pocket and waiting till we're in the air and going, because I do always think about, like, oh, this person has an open fracture, I want to get some antibiotics started. No, we don't have time for that.
That's like the
Stop
whole
being a
thing.
nurse, be a medic.
Yeah, that's like the whole thing between the ICU and the ER is, like, we always get upset in the ICU when things aren't done. But again, in the ER, it's almost the same setting like the ground. You're loading and going, and we're stabilizing the patient. And also, I loved how you mentioned the whole confidence thing, because it is almost like a dance where you have to be humble to ask questions, because if you're one of those nurses that are fully confident, you don't ask questions, or you don't want to ask questions where you want to always figure things out yourself, you're going to create a lot of shame and guilt within yourself, because you're always trying to figure that out. And that only is going to lower your self-esteem and going to do the opposite, which is to lower your confidence.
And you have to recognize that if you're trying to put on this front of, like, I know what I'm doing, when you might not, you're not prioritizing the patient. You're putting the patient at risk. When you're not able to admit the places that you're not comfortable with, you're choosing to prioritize your self-esteem over the patient. And that's something that I think that I recognized early on, because I witnessed that, and it's frustrating when you see someone choosing their pride over the patient. And that's something that I will never, I never want to do that. I never want to be the nurse that puts the patient at harm just because I want to preserve my pride. Like, you're better off admitting that you're wrong about something, or you're not comfortable with something, and benefiting the patient by admitting you're wrong. So we do what we do for the patients, not for our pride.
100%. And one last question we like to ask all of our guests before we end the show. So if you had the opportunity to have a cup of coffee with anybody one last time, who would it be and why?
I don't know. Uh, I'm trying to think. Someone in music. I think I'd want to sit down with Metallica. Just sit down with Metallica and have a cup of coffee with them. I don't know. I want to hear all about, the what life is like being on the road playing music in the 80s. And yeah, and they just seem like cool people. But I really feel like I should have been alive earlier on to enjoy, like, the rock and roll metal early on lifestyle. But yeah, I think it'd be cool to get to know them and chat with them. I don't know. It had to be someone in music. So maybe Metallica. I don't know.
Well, Madison, we just want to acknowledge you for your time here on this episode. Thank you for getting on your wealth of knowledge in flight nursing. So hopefully there's nurses or anybody listening that took some advice or got motivated to become a flight nurse. So thank you.
Yeah, of course. And I'm hopeful that, anyone who has any questions about nursing, flight nursing, about just trying to grow confidence, like, I loved chatting about all that, because I've been there, and I love talking about life, nursing, flying, all that. So thank you guys so much for having me on. It's been awesome.
Yeah, and then Madison, where can people find you if they want to reach out to you for any kind of questions regarding flight nursing or just need a confidence boost?
So I'm on Instagram and TikTok. My Instagram, it's I'll share it with you guys.
Madrose.v. I have it written
Yeah,
down.
I changed it recently because I got married recently. So I'm like, oh, I just changed it recently. And then my TikTok is, I think it's Madison. Let me see. I just started posting more on my TikTok about like flying and lifting. I am a competitive power lifter, so I post kind of just about my life and the mixture of lifting and flight nursing. But Madison.roseg, that's my TikTok. So you can find me there, and I like posting. I post videos of pretty views from flights and some nursing humor on there. So yeah.
Super cool. Thank you so much.